This is David Chu, and I'll be discussing the chapter on minimally invasive lateral and anterolateral approaches to the lumbar spine. My co-authors for this chapter are Corey T. Walker and Juan S. Uribe. All of us are at the Barrow Neurological Institute in Phoenix, Arizona. The objectives for this talk are to cover both a lateral transpsoas, lumbar interbody fusion, and an anterolateral antipsoas or ATP approach. We'll be covering aspects of patient selection, considerations of the approach and positioning, some case examples, as well as how to avoid some complications and to highlight the differences and similarities between these two procedures. Lateral lumbar interbody fusion is suitable for treating most degenerative conditions that cause central or neuroforaminal stenosis, including spondylolistheses of grade 2 or lower. Contraindications include previous retroperitoneal surgeries, such as renal or large bowel surgeries, as well as transitional anatomy, most notably at L4-5. In this instance, you see that the psoas muscle tends to be displaced anteriorly, which can also move the lumbar plexus anteriorly, which makes the approach more difficult and dangerous. In addition, patients with osteoporosis with a T-score under -2.5 are not appropriate candidates for this type of surgery. In terms of deciding on which side to approach from, what we generally like to do is look at an axial slice of the disc space, and we keep an eye on the large vessels that are close to it. So in this example, you see that the vena cava as well as the iliac vein tends to be displaced a little bit more on the right side. Our preference is to approach from the side of the vein so that when we go through the psoas muscle, we're able to retract and move the vein out of our field. The danger of coming in through the other side, we feel, is that when you cross the disc space, you can potentially injure the vessel on the opposite side since you aren't able to visualize it. Here is a case example of a patient who underwent a lateral lumbar interbody fusion. This is a 54-year-old gentleman with a previous L4 to S1 anterior lumbar fusion 15 years ago with solid fusion who now presents with symptoms of neurogenic claudication. On the MRI, you see proximal adjacent segment degeneration at L3-4 with central and neuroforaminal stenosis. Patient positioning for the procedure is done with the patient in the lateral decubitus position with the side of approach facing upwards. The hips and knees are flexed in order to relax the psoas muscle. In addition, a small bump is placed underneath the downward facing iliac crest to allow additional breakage and downward retraction of the iliac crest to open up the working space. In addition, the bed is positioned such so that the break is directly above, in line with the patient's iliac crest, again also to facilitate breaking or opening up this operative corridor, especially in patients with a high iliac crest. In order to plan the incision, perfect anteroposterior and lateral images of the patient's spine should be obtained with the fluoroscope or C-arm in neutral tilt and arc. At above L4-5, the incision is then centered on the posterior third of the disc space. At L4-5, it's centered in the midpoint of the disc space. This is due to the natural anterior sweep of the lumbar plexus, and at L4-5, it's notably more anterior than it is at the higher segments. This is an operative video of the approach. After the incision is made with a 10 blade, electrocautery is used to dissect down until we encounter the external oblique fascia. In older patients, this fascial layer tends to be very thin and almost non-existent. We then take two blunt tonsil clamps, or Kelly clamps can also work, and we gently, bluntly dissect through the muscle fibers of the external oblique, internal oblique, until we visualize the transversalis fascia. You can see it here, this thin white membrane, and directly underneath the transversalis fascia, you'll notice plenty of retroperitoneal fat, which will signal that we've gained retroperitoneal access. Going through the fascia, you can either puncture it bluntly with the tip of the clamp, or just keep on dilating and spreading. And eventually, when it opens up, you'll see a significant amount of retroperitoneal fat, verifying that you have gained access. After gaining retroperitoneal access, a blunt dilator is then inserted through the psoas muscle, and then directional EMG monitoring is stimulated through the dilator in order to verify that we are anterior to the lumbar plexus. After we verify that, sequential dilation is then performed over the initial dilator and then a minimally invasive lateral retractor is docked onto the lateral surface of the disc space. After gaining adequate exposure, a discectomy is then performed, first with a 15 blade to create an annulotomy, and then portions of the disc are resected with curettes. An important technique is to release the contralateral annulus under AP fluoroscopy with a Cobb elevator. This enables correction of coronal deformities and placement of larger implants, as you see in this sequence. After preparing the disc space, the final implant is then inserted, and ideally its length should span the entire lateral width of the disc space from apophyseal ring to apophyseal ring. So this 54-year-old patient, after undergoing the procedure, remained neurologically intact and was discharged home the following day. We obtained a postoperative MRI prior to him returning home, which showed excellent indirect decompression of the thecal sac. Here are the preoperative images on sagittal and axial slices, and then postoperatively you can see the significant ligamental taxis with reduction of the central and neuroforaminal stenosis. Now we're going to turn our attention to an anterolateral or antipsoas approach. Similar to a lateral transpsoas approach, an antipsoas approach is able to treat most degenerative conditions except for spondylolistheses of Myerding grade 2 or higher. It's also able to access the L5-S1 disc space, but requires a specialized approach, which will not be discussed in this talk. The contraindications are essentially identical to a lateral transpsoas approach. Previous retroperitoneal surgeries, transitional anatomy, as well as significant osteoporosis are all contraindications for an antipsoas approach. One last difference is that the side of the approach is generally limited to the left side in order to avoid proximity to the large veins on the right side. Here is a case example of an antipsoas approach. This is a 71-year-old woman with a previous L3-4 posterior instrumented fusion who has had intractable right radiculopathy as well as neurogenic claudication. On imaging, you can see that there is evidence of a distal adjacent segment disease with central and neuroforaminal stenosis at the L4-5 level. Patient positioning and incision planning for antipsoas approaches are similar to a lateral transpsoas approach. The patient is in the decubitus position, the hips and knees are flexed. Incision planning, however, is more complex and first begins with a lateral projection of the disc space on the patient's flank. You then measure from the midpoint of the disc space in a line along the same trajectory as the disc space anteriorly to a length of approximately 8 centimeters. The new incision that we then plan out is centered on this line and typically spans about 4 to 6 centimeters depending on the patient's anatomy and surgeon comfort. An ATP approach is similar to a lateral lumbar interbody fusion in the beginning in that retroperitoneal access is gained in a similar fashion. Once in the retroperitoneum, though, we do need to identify and visualize the anterior belly of the psoas muscle and ensure that the peritoneum is well mobilized ventrally in order to protect the ureter, which is typically adherent onto the peritoneum. The anterior belly of the psoas muscle is then mobilized or retracted posteriorly. In patients with a bulky or tense psoas that is unable to be mobilized posteriorly, blunt dilation can be performed through the anterior portion of the muscle, similar to a lateral transpsoas approach. Finally, when dilating through the psoas muscle, neuromonitoring typically is not needed as the approach is anterior to the plexus itself. Here's an example of the exposure. This patient had a high iliac crest, which made her unamenable for the lateral lumbar interbody fusion. This line is actually the anterior superior iliac crest line. This is the actual planned incision line. Now, the initial approach is similar to a lateral transpsoas approach. The skin is incised, and then electrocautery is used to dissect down through the soft tissues until we enter the external oblique fascia. We then dilate through the flank abdominal musculature until we encounter the transversalis fascia. Here we are dilating the transversalis fascia itself, and you can see retroperitoneal fat. Blunt finger dissection is used to mobilize the peritoneum, and then vein retractors are inserted. This is the anterior surface of the psoas muscle. A sponge stick is then used to mobilize the peritoneum further, and you can see muscle fibers as well as this superficial nerve running on the surface. Endoscopic kit nerves we find helpful to dissect through additional adhesions between the peritoneum and the anterior belly of the psoas muscle. And you can see right here that the psoas muscle is entirely, completely free. We then place a retractor underneath the anterior lip of the psoas muscle, and then proceed to actually retract the psoas muscle posteriorly. And this will actually gain access and expose the disc space directly underneath the psoas muscle. You can see the white annulus there. We check with X-ray that this is the disc space we're targeting. We insert a small guide wire just to act as a fiducial, and then insert a minimally invasive anterolateral retractor, which is centered on our disc space. This is a view of the final exposure, and then we proceed with discectomy. We incise the annulus and then do our initial discectomy prep with curettes and rongeurs. Angle instruments are helpful in order to provide a perpendicular working trajectory. So, taking off from the video, as mentioned, angle instruments help us work near a perpendicular straight lateral working angle, as you can see with this lateral radiograph. This space is then released with a contralateral annulotomy with the cob, similar to a lateral transpsoas approach. Here you can see that. The implant is then packed and inserted at an oblique angle. Before the implant is inserted to its full depth, it's very important to check a lateral projection X-ray to make sure that the implant isn't at an oblique angle and isn't at risk of entering the spinal canal. And here in this X-ray you can see that we have good clearance of the spinal canal. It's inserted fully at a full length, expanding the disc space, and the procedure is complete. Postoperatively, the patient did very well and was discharged home on postoperative day 2. Again, a postoperative MRI on post-op day 1 showed that the previous preoperative MRIs showing central and neurofibrinoid stenosis were indirectly decompressed significantly, and the patient did very well. In conclusion, transpsoas and anterior to psoas approaches to the lateral lumbar spine have significant overlap in terms of patient selection and surgical principles. A safe approach through a transpsoas approach requires directional EMG monitoring to ensure that the corridor is anterior to the lumbar plexus. An antipsoas approach requires more direct visualization of the pre-psoas plane or the anterior belly of the psoas muscle. And both surgical techniques mandate accurate localization of the implant and the insertion trajectory through either high-quality fluoroscopy or stereotactic neural navigation. Thank you for your time.